We present to you our new technique of arthroscopic transscapular lower trapezius transfer for non-reparable subscapulary stairs. This is a left shoulder. The procedure is started from the posterior incision with an exposition and an harvesting of the lower trapezius as it was described previously by many authors, but first described by our senior author, Bassem El Hassan. Then a split is performed in the infraspinatus after opening the infraspinatus fascia widely. It's important to stay below the level of the spine of the scapula in order to perform an osteotomy, and quite medial to the sphenoglenoid notch in order to be away from the branches of the suprascapular nerve to the infraspinatus. Then, when the osteotomy is performed, we can reach the subscapularis fossa anteriorly, and it needs to be followed until the anterior glenoid rim. It's very important to thoroughly follow the subscapularis fossa to remain away from the thorax that's anterior and from the neurovascular structures laterally. Once everything is prepared, including the shuttle relay, we go arthroscopically and prepare the anterior glenoid rim, open the anterior capsule, and then switch the visualization to an anterolateral portal in order to follow the subscapularis fossa. It is mandatory at this level to perfectly expose the axillary nerve and radial nerve from the posterior cord in order to prevent their damage with the shuttling of the graft. Then a debridement of the subscapularis fossa with the remnant subscapularis is performed until the osteotomy level is reached and we can get back to our shuttle relay which has been placed initially. Then a simple shuttle suture is brought from the lateral visualization portal to the back of the shoulder, and an allograft, which is most of the time an Achilles tendon allograft, is brought from the back of the shoulder to the anterior aspect of the humeral head. It is then a quite standard fixation of this allograft on the lesser tuberosity at the level of the footprint of the subscap. We try to fix it as largely and widely as possible in order to create a real footprint and in order to augment the potential chances of healing of this allograft on the lesser tuberosity. Tenodesis of the biceps is performed and a whole partial repair of the rotator cuff, including the remnant subscapularis, is performed. We then suture the allograft to the very tensioned lower trap. What is very important is that the suture from the graft to the tendon of the lower trap is far away from its entry point inside the osteotomy. We therefore control with passive mobilization that the suture of the allograft to the lower trap tendon doesn't get stuck inside the osteotomy, and the postoperative care allows a passive mobilization up to 0 degrees of external rotation in order to prevent ossification of the scapula around the allograft.